If we're having this discussion here with experts on this, and it's complicated, and I must tell you, listening to this, I understand what you're saying and I'm following you, but it's not trivial. What about the folks out there, the neurologists, the family physicians? I hate to use the word general practitioners because that's not politically correct anymore, but people who see all comers. How do you expect them to be educated?
So what is the slam dunk? The major form of MS presents with attacks.
Okay.
It's important to think about MS, to make that diagnosis as early as possible, and to get them on treatment early. And you hope that they do swell. You hope that they don't transition to secondary progressive MS. And you can keep them intact, also adding a wellness program and symptom management, et cetera. That's what the general practitioner should really be focusing on.
Can the general practitioner be relied upon to make the initial diagnosis? On physical exam, get the right lab tests, call up, get pre-approval, get the MRI.
Simple question. Do they meet 2017 McDonald diagnostic criteria? If the private practitioner is a deer in a headlight, no, they shouldn't be making the diagnosis. If they're not using those criteria, in my opinion, they shouldn't be making the diagnosis.
Do primary care physicians, right now, if you lined up 100 of them,
right,
and you said McDonald criteria, would they know what you were talking about?
No.
Okay,
no.
So the answer,
they shouldn't be making
so
the diagnosis.
question comes back to, are they educated, providers, patients, payers, and if not, why not? And can we make that better?
Well, I think people have tried to educate them. If somebody goes blind in one eye and they have pain in moving the eye, I think most people recognize that's likely an optic neuritis and they should get that patient seen, right?
Right. But this is a far more complex diagnosis.
But it becomes then, look, once a patient is diagnosed with multiple sclerosis, this diagnosis sticks for life. So this is one of these life-changing diagnoses. And from that point of view, a primary practitioner, a primary care practitioner is probably more somebody that identifies that somebody may be at risk and then requires a neurologist to see this particular patient.
Okay, that's what I wanted to get.
A neurologist in general, because we will go over many different medications. This sounds a little bit like oncology, where it becomes more complicated what we do with individual patients, and there are complexities that we are not going to address today. A general neurologist, a community living neurologist, will then have perhaps a special interest in MS, or he's somebody that is more electrophysiologically inclined. Again, that person says, I think this is MS, and may refer to an MS center, or says this is a clear case of multiple sclerosis, I will start treatment at that point in time. But I don't think that for a lifelong illness with the potential impact of multiple sclerosis, the place of diagnosis is in the primary care physician's hands.
Totally agree.
And I think we agree as well, especially when you then initiate, because this is sometimes how we come to know the patient that has MS, is when they're placed on disease-modifying therapies. And then at that point, we do require that a specialist has been involved, has confirmed the diagnosis in order to approve the therapy.
And I don't want to cast any aspersions on primary care physicians. To me, that's an impossible job. Everybody comes through your door with plantar warts to hangnails to multiple sclerosis. And how you expect these poor folks to be up to date on every specialty's tests, every specialty's diagnostic criteria, every specialty's package to establish the diagnosis. I don't think that's possible.
But we mentioned another very important part of the role of the primary care physician. Once the patient has been diagnosed with MS, patients are very often overburdened with the diagnosis of MS. And it's then, from a neurologist's point of view, very important to have a partner in the general practitioner, the primary care practitioner, to take care of the comorbid conditions, because as we have discussed, these can modify the course of the disease very significantly. And so to then be a partner in the care of this individual. So when a patient is identified as having multiple sclerosis, that patient will have another part of the care teams that addresses specifically the MS issues, but the primary care remains very important.
I completely agree. This aspect of comprehensive care and even a medical home for the patient that has MS, because patients are, no patient is alike. Some of these patients are young women in the prime of their lives contemplating pregnancy, for example, or they're pregnant or they're postpartum. And so the need, if you will, for comprehensive care that brings in multiple disciplines and that can help the patient and the family in terms of a lifelong disease is critical.
So it's referring, not sending away. Right?
I mean, I think that's really important because if there's one thing we know that primary care physicians are good at, it's taking care of the whole patient. Perhaps someone's going to help them with a very technical diagnosis, but that patient's coming back to the community, and that patient's going to be managed by somebody, and that patient is probably going to be managed by their primary care physician. Makes sense.
Absolutely.